So, what other kind of potential options do we have? You talked about clinical trials. There's a lot of interest around immunotherapy. I feel like we're still trying to find the right secret sauce for that. But we've had a couple missteps. And what do you think about immunotherapy?
I think immunotherapy is interesting. We haven't figured out what patients are going to benefit and how to give it.
Mm-hmm.
Javelin 200 was just reported at our annual meeting for Society of Gynecological Oncology in Hawaii. And so we haven't seen the paper, but we have seen the presentation.
Mm-hmm.
And unfortunately did not meet its primary endpoint. So platinum resistant, they were not allowed to have other therapy for their platinum resistant disease, but they were allowed to have 1 to 3 priors for platinum sensitive disease, okay? And then it was a 3-arm trial, avulimab, PLD plus avulimab, or PLD, 1-to-1 to randomization.
Mm-hmm.
So interestingly, when we look at that patient population, the primary outcome was not met, but there's some very interesting findings when we looked at the PD-L1 positive population.
Okay.
The overall response rate was about 18.5% when we looked at the combination of avulimab plus PLD, and that's compared to only 3.4% in PD-L1 negative population.
Okay, before we go on further than that, because I think that's a good point, I wanted to ask our pathology expert, what about the, what are we assessing with this? Because it seems like there's many different assays. Lung cancer, they got this, and each drug company has their own assay.
I think Dave hit the nail on the head. Obviously, there's so much excitement about immunotherapy, but
Right.
but how you actually define who's going to respond, is a big issue. And certainly with the MSI population and certain DNA polymerases, it seems like you get high responses associated with tumor mutation burden. But there's tremendous interest, or maybe not so much tremendous interest, because with the pharmaceutical companies, it may not be in their best interest, I think, to necessarily narrow down the population. But with the PD-L1, just some general things, to keep in mind is there are a number of different clinical antibodies that are being used, and so whatever study you look at, you want to look at what antibody specifically was used there, and then there's different assessments and different cutoffs. So kind of as you touched on with lungs, sometimes they have they're only looking at the tumor cells, so the positive tumor cells, and then the cutoff might be greater than 50%. And then other studies, they're looking specifically at the tumor cells and the immune cells. In the Javelin study, they had their cutoffs at 1%, greater than 1% in tumor cells, or greater than 5% in the infiltrating immune cells. And so, but even with that, you have to take a little bit with a grain of salt. Is where is this biopsy coming from? Was the staining performed on a lymph node versus a primary site? So I think there's a lot of caveats still to kind of interpretation of this. But there does generally seem to be some type of benefit, obviously in the PD-L1 positive population, which seems to make sense with the way the drugs should work.
And the way they define it, about 57% of patients were defined as PD-L1.
Yeah.
So about half, or just over half, by their definition. We don't really know what the definition in GYN cancers really means.
Yeah, it's
right?
all over the place, right? Because of what he just mentioned. I think we saw in the Keynote 100, in the ovary subpopulation, also a very large group of patients, that your greater than 50% score was about a quarter of patients. The less than 1% was about a third of patients, and there's all these patients in the middle. So it's like wherever you draw the line is going to give you whatever that proportion is. So and it's interesting, I think, also that some of the very earliest data we have in platinum-resistant patients, and maybe this is the wrong population to study, but in platinum-resistant patients, that there were responders and expressors and non-expressors. We had that data right away. So we're getting a larger denominator, But I'm not so sure that we're actually increasing the numerator by all that much with all this intervention that we're doing, in terms of the efficacy. So how do you guys use, at your place, how do you use
PD-L,
PD-1,
we don't
immune
test it.
checkpoints?
We don't actually. So checkpoint inhibitors, when you look at all the checkpoint inhibitors that are out there, of course, we're looking at response rates anywhere between 5% at best, 20%. And so we don't necessarily, off the top, we don't test for PD-L1. And if we choose to give someone a checkpoint inhibitor, it's usually in the context of a clinical trial, which kind of brings me to the own point, we're looking at immunotherapy in conjunction with good old-fashioned chemotherapy, but are there new and more novel options, combining a PARP inhibitor with, immunotherapy, and what's the rationale? And is the rationale only in a BRCA mutation carrier versus, for example, the Tapatio study, which was a small study, granted, was 25% overall objective response rate, irregardless.
Which is kind of interesting, right?
It's kind of interesting.
Yeah.
It kind of it's food for thought. And what's the idea behind that,
Oh, give me that face, David.
Well,
It's a start.
but it also brings us into a whole different conversation with how about PARPs in this patient population.
Well, I was just
and
going to ask you that.
combination, So, but I want to kind of look at this because I think there is some interesting data out of Javelin that we should discuss. In across our immune therapy trial, single agent, it's amazing. 5% plus or minus 5%.
Right.
As low as 0 up to 10, but nothing beyond that. Yeah. And we saw the same thing in Javelin, where we saw avutometinib alone was 3.7%. Yeah. PLD, this comes back to this platinum-resistant population. I quote my patients 15 to 20%. Yeah. In Javelin 200, it was 4.2% objective response rate. Okay.
By BICR. So it's by BICR.
BICR,
all the data you're
minus,
quoting is by investigator assessment.
Okay.
But in general. But you're right. I get it. It's lower than expected.
Correct. And when we use the combination, it did go up to about 13%.
Right.
And that's in the entire population, not the PD-L1. When we're looking at the differences between this, again, when we look at the avutometinib arm in all comers, it really looks like the natural history of the disease.
Yeah, right. Yeah.
60% fell off at the first assessment, which was at 2 months. Another almost 30% fell off at the second assessment. So it's a really, by itself is probably not where we should be going right now. Now all checkpoint inhibitors are not created the same, so maybe there's some other data out there.